Welcome to this explainer on the GINA 2024 Strategy Report. I am genuinely thrilled to walk you through this material today because, honestly, we are looking at some massive, fundamental paradigm shifts in modern asthma care. The Global Initiative for Asthma has been meticulously updating these strategies, and the 2024 report completely redefines how we approach the whole shebang, from initial diagnoses to daily management, right down to emergency flare-ups. We're moving far beyond those old habits of just treating symptoms as they pop up, and instead, we're shifting our entire focus toward long-term risk minimization.
To really grasp why this shift is absolutely crucial, we have to look at the sheer scale of the issue. Asthma currently affects roughly 300 million people worldwide. And get this, despite all of our medical advancements, all of our incredible modern technology, it still causes around 1,000 deaths every single day. That is a shocking, frankly unacceptable reality in modern medicine. And you know what's truly heartbreaking about that statistic? The vast majority of these deaths are entirely preventable. They're basically the result of outdated treatment methodologies, underdiagnosis, and this heavy over-reliance on quick fixes that completely ignore the underlying chronic inflammation.
Okay, let's dive into this explainer's clinical roadmap. We'll be looking at 1. Defining the asthma paradigm, 2. Diagnosing asthma accurately, 3. The 2024 treatment tracks, 4. Managing asthma exacerbations, and 5. The goal of remission.
Starting off with Section 1, Defining the Asthma Paradigm, beyond just symptoms.
So we really need to move beyond the old simplistic assumption that asthma is just about wheezing when you exercise or catch a cold. The 2024 guidelines demand a much more comprehensive understanding of the disease architecture. So the crucial point here is this dual requirement. The GINA definition requires a history of respiratory symptoms that vary over time and in intensity, paired directly with variable expiratory airflow limitation. It's a heterogeneous disease. This means that while chronic airway inflammation is usually the culprit, the way it actually presents from patient to patient can be wildly different. You literally cannot diagnose asthma based on a single symptom, and you definitely can't diagnose it without proving that the airflow limitation actually fluctuates.
Because it's so heterogeneous, asthma isn't a one-size-fits-all monolith. It's honestly more like a fingerprint. The 2024 report highlights several distinct clinical phenotypes. You've got your classic allergic asthma, which responds great to inhaled corticosteroids, but you also have non-allergic asthma, adult-onset asthma, and asthma driven by obesity, which actually often features very little eosinophilic inflammation. But what I really want to highlight here is cough variant asthma. In a lot of patients, both kids and adults, a chronic cough might be their only symptom. They might never present with a classic wheeze, and their initial spirometry might even look perfectly normal. Recognizing these distinct phenotypes is step 1 in true personalized medicine.
Moving on to Section 2, Diagnosing Asthma Accurately, Tasks Before Treating.
And this brilliantly illustrates exactly why we must document evidence of variable airflow limitation before starting an ICS-containing treatment. Why? Well, because inhaled corticosteroids do exactly what they're supposed to do. They reduce inflammation and stabilize the airways. If you treat first and test later, the ICS is going to mask that variability. You'll literally erase the very diagnostic evidence you need to confirm the disease, which could potentially lead to a lifetime of misdiagnosis or completely inappropriate therapy.
So breaking that methodology down into specific steps, it always starts with identifying those typical variable symptoms, things being worse at night or getting triggered by exercise or a viral infection. Then you confirm the expiratory airflow limitation, ideally with a bronchodilator reversibility test using spirometry. But the GINA report is highly practical here. It completely recognizes that many clinicians globally just don't have access to spirometry. In those cases, tracking peak expiratory flow, or PEF, is a totally valid substitute. While it's a bit less reliable than spirometry, tracking peak F variability is infinitely better than just relying on symptoms alone to make a clinical diagnosis. Once confirmed, then and only then do you initiate ICS treatment and review the response.
Let's move to Section 3 and see how this builds. The 2024 treatment tracks, the ICS paradigm shift.
Now this is where we see the absolute biggest, most life-saving shift in modern asthma care. We are completely abandoning the idea of treating asthma with short-acting beta-2 agonists, or SABAs, alone. We now have 2 highly defined tracks. Track 1 is the preferred track. It uses ICS formoterol as an anti-inflammatory reliever, or AIR. This means every single time the patient reaches for their inhaler for symptom relief, they are simultaneously getting a dose of an inhaled corticosteroid to treat the underlying inflammation. This mitigates severe exacerbations brilliantly. Then there's track 2, the alternative, which uses a traditional SABA reliever alongside a daily maintenance ICS. But the GINA report is super explicit about this. SABA-only treatment is dangerous and totally outdated. If a patient is on track 2, they absolutely must be compliant with their daily ICS, otherwise they're just masking symptoms while their airways quietly inflame. Track 1 is preferred precisely because it completely solves this adherence problem.
Treatment within these tracks operates on a sliding scale from step 1 all the way up to step 5. For example, in track 1, steps 1 and 2 involve using low-dose ICS formoterol purely as needed. If symptoms are uncontrolled, you step up to step 3, using it as maintenance and reliever therapy, which is often called MART. If things get highly severe, you scale up to step 5, which introduces add-on therapies like LAMAs, long-acting muscarinic antagonists, or biologic therapies. But remember, this isn't a set-it-and-forget-it kind of system. Therapy has to be continuously assessed, adjusted, and reviewed based on symptom control and exacerbation risk. You step up when needed, and just as importantly, you step down when the asthma is well controlled.
Of course, when we're empowering patients to use ICS formoterol as both their daily maintenance and their as-needed reliever, we have to establish really clear safety boundaries. Think of it like a clinical speed limit. It's vital to communicate these boundaries. The GINA 2024 report provides exact safety thresholds. For adults and adolescents on track 1 MART, the maximum total dose of formoterol in a single day is 72 micrograms metered dose. To put that into perspective, if they're using a 100/6 microgram inhaler, that means a maximum of 12 inhalations in a single 24-hour period. Keeping patients aware of these limits ensures their cardiovascular safety when they're out there managing their own flare-ups.
All right, Section 4, Managing Asthma Exacerbations, Minimizing Oral Corticosteroids.
Now, what's really interesting about this is how the underlying philosophy has changed, because even with perfect adherence to track 1, exacerbations will happen. But how we handle them, completely different now. A severe exacerbation is no longer viewed as just an unfortunate bump in the road or a normal part of having asthma. According to GINA, an exacerbation is a system failure. It demands a complete systematic review of the patient's treatment. We can't just hand out a burst of oral steroids, pat the patient on the back, and send them home anymore. We have to optimize their daily regimen to actively prevent the next attack.
So what are the actionable steps here? Post-exacerbation, assessing medication adherence is your absolute first priority. Are they actually taking their maintenance dose? Next, evaluate their inhaler technique to ensure the medicine is even reaching their lungs. Depending on what you find, stepping up their controller treatment is very likely necessary. And above all else, minimizing OCS use is paramount. The cumulative long-term adverse effects of oral corticosteroids, we're talking osteoporosis, diabetes, cataracts, they are devastating. By leveraging track 1 and optimizing inhaled therapies, we can drastically reduce our dependence on systemic steroids.
And finally, Section 5, The Goal of Remission, a New Standard of Care.
This is, frankly, the most exciting development in modern pulmonology. We are no longer just trying to keep patients out of the emergency room. The 2024 guidelines formally introduced the framework for clinical remission. This is defined as a state of long-term symptom control and risk minimization. It means no sleep disturbances, no daily symptoms, no exacerbations, and halted lung function decline. And the most crucial part? This is entirely achievable whether the patient is completely off treatment or tightly managed on treatment with optimized ICS formoterol or biologic therapies. It proves that with the right, highly structured care, asthma just does not have to be a daily burden.
Thank you so much for joining me for this explainer. I want you to look at your own practices and ask yourself, with these incredible evidence-based tools at our disposal, shifting our entire focus from temporary symptom relief to aggressive long-term risk minimization, is clinical remission finally within reach for all of your patients?